Let's dive right into this, the level one, and let's start with a very important point that you expressed, which is the timely diagnosis. What do the guidelines state about timely diagnosis? Who's accountable for ensuring a timely diagnosis? And what does this mean for patients who need to advocate for their rights?
So that's a wonderful question, and thank you, Kim, for asking that question, because at the end of the day, if we don't make the diagnosis, as they say, the rest is history, meaning that unfortunately the patient doesn't get the treatment if we don't make the diagnosis. And with all the technologies and resources that we have out there, both medically and with devices, we will lose the opportunity to treat our patients. So it is definitely an opportunity for us to be able to diagnose the patients in a timely fashion. So the guideline is very clear, very clear. They say that you need to perform an ABI or an ultrasound or a CAT scan, some kind of imaging, to diagnose patients that have PAD with ulcers and gangrene. So anybody that is CLI, we call it, as you know, and your participants are familiar with this terminology. So these are patients that have ulcers and gangrene. Many of them are diabetic, that are at risk of losing their leg. The guidelines make it very clear, is a level one. Every patient that has any form of an ulcer or gangrene, they should be getting an ABI or a duplex ultrasound or both, or get a CAT scan or an angiogram, something, so that we can make the diagnosis of whether they have vascular disease or not. That's one. The second point is that anybody that has symptoms with claudication, so anybody that doesn't have an ulcer or gangrene, but when they walk, they get the calf pain. And then when they rest, the pain goes away. We call those patients those that have claudication, that PAD, that blockages that cause ischemia when they walk. Those patients should be evaluated with an ABI, a routine ABI. If the ABI is non-diagnostic, meaning that they have non-compressible arteries, or for some reason is not accurate, they recommend an exercise ABI for those patients. That's all level one. So when we do ABI for PAD, normally it's done at rest. But our patients don't have pain at rest. When they're sitting, they don't have pain. They only have pain when they walk. That's the definition of claudication. Claudication is when you walk and you get the calf tightness, and when you rest, it goes away. So by definition, if you just do a rest ABI, you are not getting a thorough assessment of what the perfusion to the leg is when the patient is having pain. So the guidelines make a recommendation, that a 2A recommendation, you can do exercise ABI to truly assess what the patient is perfusing, what is their number when they are having claudication. So again, the guideline is very aggressive with diagnosis of PAD. And there's also something else that I want your audience to be aware of, and this is very important, Kim. PAD is the strongest predictor of mortality and cardiovascular events than any other risk factor that we evaluate. So when we go to our doctors, they say, do you have high blood pressure? Do you have diabetes? Do you have family history of heart disease? Do you have high cholesterol? Do you have elevated Lp(a)? And all kinds of things. Of all of those things, the strongest predictor is PAD. If you have PAD, your risks are very high. And even if you don't have symptoms, even if you have no symptoms, you have no ulcers, no gangrene, no pain when you walk, just you've been diagnosed with PAD, that's a very powerful kind of a risk factor to know. So if you get an ABI and you have an abnormal ABI, we know that your LDL cholesterol, for example, should be less than 70. PAD is equivalent to diabetes and coronary disease. So when I see a patient that has had a heart attack, and I see another patient who's never had a heart attack and has never had a symptom, but their ABI is less than 0.9, to me, they are the same. I see them with the same lens from a standpoint of risk and future events. And that's very powerful because we can be very proactive, identify patients at risk of having bad outcomes over time, and be aggressive with risk factor modification, get their LDL below 70, get them to do exercise, quit smoking, control their hypertension, and so on and so forth. There is so much that we can do. I mean, we can get into it, but there is a lot of things that PADs are very powerful predictors of bad outcomes, and we need to educate and diagnose our patients.